شكرا جزيلا Mr. Chairman. It is my pleasure to be here, and thanks to the organizing committee for letting me speak to you today after these many eminent speakers. First of all, I want to thank all the organizing committee, especially Professor, the chairperson. Professor Khalid Abu Saif, and I will not speak about the others, but I will just mention one phrase to Dr. Magdi يا أخويا. كلمة واحدة أغبطه على هذا المجهود زي دكتور حسين والدكتور زغلول في the last 1 month or so. They did a lot of job. They serve our country much better than quite few like myself. And to be in English, this is the good part of jealous. All right, this is my first introductory slide coming from the Clothica in Alexandria. And coming from Alexandria, I just want to mention that you are all welcome in Alexandria 2014 for our annual conference, which will be in a collaboration with the Arabic Society of Nephrology. I wake up this morning, find that today is the 6th of October, so I had to put this slide, if you allow me, because this is long time ago, 1973, about maybe 40 years ago, and man abara yastati'u an ya'bur. And like this one, but I will just mention one thing, that we must do it by work, not by stand like we believe we do. These people who cross the borders and do the victory, our fathers and brothers, even never think of their needs. Actually, what they didn't stand for their needs. In contrast, they actually live their country, Egypt, needs, and die for that. And that's the main difference between us and them, and I will mention this in Arabic, al-bawn shasi', and actually not big in the difference between us and the American, but between us and ourselves in 40 years ago. Right, going to business, and this is the title. I thanks Professor Magdi, and thanks for his help. If you find anything good in this lecture, after Allah subhanahu wa ta'ala, it will be for Magdi, because he provided us with a lot of data and about the volume expanded in hemodialysis patient. Is it congestive heart failure or fluid overload? And I will start by a case, just an introductory case. A known cardiac patient, uremic patient, come to you because of dyspnea, orthopnea, and shortness of breath, and congested liver and neck veins. And the question is it congestive heart failure or fluid overload? How to differentiate? Does it really matter to differentiate? Do they really differ? And if so, how does it really affect your management? And can they be both combined in the same single patient, and what is the implication for that? And does the underlying pathophysiological mechanism have an impact? But actually remain a preliminary and important question is, who is your patient? Is it AKI or CKD or hemodialysis, as we shall concentrate today, or PD or transplantation? Because the material, your subject will differ. And you may think, all right, I will do a bunch of lab, including echo, PNP, and different things, but you will find that this is maybe misleading and not answering the point. This is another case in the net, and the daughter said to the expert, my father had a massive heart attack since 40s, and a second one on the 60s, and he's now 72, living alone in a facility, has fluid issue, has got Lasix and Urinex, and has very little quality of life for the past 8 years. and his wife died 10 years after his first attack. And just she claimed that the doctor said that he has got only 25% of his kidney function. And the question is, I understand that edema, which is our topic today, could end up being the biggest issue and could die of pneumonia. But honestly, he is easy to pass on to be with my mother and has been for years. And she asked it what to do. So the agenda, in short, a general review, why it is important and what is relevant, and the pathophysiological basis, and how to differentiate. Do we have a combination best treatment to remove the fluid, and back to the case, and maybe take a home message and my last statement. This is actually done about 10 months ago in San Antonio, and this is the same topic which I will address today. The dialysis patient actually is a survivor, but actually he's a survivor of the pre-dialysis CKD period, but with a burden, with a high cardiovascular burden. And the sodium and the overload are parts of the main players between CKD and the heart. As you see here, they have as high sodium and low potassium, and this will cause high sodium and low potassium and high aldosterone, and this is bad for the vessels, causing this stiff endothelial cell and endothelial dysfunction. In contrast, as we said, of low sodium, high potassium, and low aldosterone. And there is a role of this inhibitor of sodium-potassium bonds, because this chronic volume expansion leads to inhibition of vascular AT base, increasing sodium and calcium, causing vasoconstriction, increased blood pressure, and causing natriuresis. But actually, this is if the mechanism is working. There is a correlation between left ventricular mass and extracellular fluid. So increasing the fluid will increase the left ventricular function in the NDT 2008. There is also, even in the CKD stage 1, 2, 3 patient, there is still increase, even with decreased GFR, there is increased extra fluid accumulation, and there is a daily natriuresis of this. Not also that, but the pulse wave velocity increasing as a marker of endothelial dysfunction, increasing in CKD stage 3 in comparison to the control and stage 1, stage 2. And if you compare a normal non-CKD patient, they have got an inappropriate left ventricular mass in 30%. But if they are stage 2 or 5, we're going to 20, 52%. And it is climbing up as we progress in the CKD. Not only the mass, but the left ventricular remodeling in CKD will increase with increase in the creatinine clearance and reaching up to dialysis as remodeling. Not only the systolic, but also the diastolic function will decrease with the advancement or the progression of CKD. And this data come from the American Journal of Kidney Disease about 10 years ago, about the cardiovascular situation in dogs. In Japan, they have only congestive heart failure 6% in comparison to the US. And this may be the US taking everybody and dialyzing. We have a coronary artery disease 19% versus 50% in US. And the Europe is in the middle. Why this subject is important? Important because there is a death related. There is an increased death, even to see, increased death even more than to go to dialysis or follow up. Also, if you compare your 20 years patient with end-stage renal disease, he have a liability of mortality equivalent to 80 years of the general population. So being an end-stage, liable to die earlier, because mainly are cardiovascular. Not only that, the diabetic actually will progress not only to end the stage, but will die much more if you combine diabetes with CKD. and the end-stage renal disease constitute even the most common mortality before colon cancer in the US citizen and just after the lung cancer. And the dialysis population combined with age have the expected remaining time a very little less than 3 years with age, including if you are going to dialysis. And this is to compare that even in different modality in different countries, as Japan and the US RDS has got a mortality rate after 5 years of 20 to 40% according to the country. And this is to illustrate that even the dialysis start in 19% of CKD4 and the deaths approaching 50%. What about heart failure in the incident of dialysis patient? If we have in this study in KI-95, long time ago, 400 patients, there is congestive heart failure at the base. Some have got some and nothing, but by dialysis, the recurrence of congestive heart failure will increase to 75, and the patient who having got a congestive cardiac failure will develop, about 1/3 of them develop congestive heart failure. We are still in the importance of speaking about subject. What is the commonest cause of emergency admission of your dialysis patient? It is actually pulmonary edema. It is about 26% of your patients. And what is the main cause of this acute pulmonary edema? You have excessive intradialytic weight gain, inappropriate dry weight prescription, hypertensive crisis, ischemic heart, and the dialysis discontinuation, beside heart failure and others, and hyperhydration, which is our topic. So as Mr. Kane mentioned, the difficulty lies not in the new ideas, but in escaping the old ones, which ramify for those brought up with them, as most of us have been into every corner of our minds. The intermittent fluid retention is correlated so much with the cardiovascular mortality, and actually this is item 1 year ago changed my practice, because I love my patient to be a little bit wet, but actually they told us by different data that it is better to keep it dry. And this is to illustrate, if you have an intermittent fluid retention, your patient gaining much fluid in between the dialysis, he will die much, much earlier. Not only the intermittent, but even the chronic fluid retention will be related to mortality. If you have a chronic fluid retention, you will die much, much easier. The interdialytic myocardial stenting in 45 among 70 hemodialysis without severe heart failure present with regional wall motion thickness. And the associated precipitating factors is age, diabetes, and see what is this? Ultrafiltration rate. And I will go to this in a minute. Associated with long-term degradation of cardiac function, and this is in the JSON about 3 years ago. The association between ultrafiltration and cardiovascular and all-cause mortality like this curve. And if you see this 10 mean 10 milliliter per hour per kg, this means to ultrafiltrate your patient maximum 1 kilo if he's on 100 in 1 hour. My residents keep me happy, said I get out of him 5 kilos in a session. So he will keep my patient die earlier, because if you see, and this is abrupt increase in the hazardous of mortality if you remove from your patient more than 1 kilo, to make it simple, per hour. And it is more hazardous if you take it 1.5. This is the cut, and it is a rather recent paper in the KI 2011. So by this instant, the normal heart in hemodialysis patient, probably not for most of our patients. And that's the effect of the fluid overload. What is the relevant for volume overload patients? Effective fluid removal on the cardiac function. Of course, if you remove the fluid, the ejection fraction will be better. There is a cardiac function improvement with fluid excess removal, and this is 4 years ago. Another paper long time ago in NDT, saying that ejection fraction improvement on fluid excess removal long time according to the patients. So how we can differentiate between congestive heart failure and the hypervolemia without a heart failure? Do we have the tools? Yeah, there is two main things you may think about. High frequency hydration body and the PNP, which was mentioned earlier about 2 hours now in the study. This is a paper coming from the Jason showing that ANP will increase, but as you see, and the PNP increase if it's related to concentric remodeling, eccentric remodeling increasing by time. This is a factor which you may think about, and this is 10 years ago. Not only that, but if you compare PNP with a congestive heart failure in comparison to others, can discriminate if your patient has got a congestive heart failure versus hydration. And this is proof what we call it recover operating characteristic curve. And also, if you have a pulmonary impulse, you may be astonished that PNP is still high despite that the patient hasn't got a congestive heart failure. But look to your COPD and the fibrosis, there is no PNP increase. And if you compare congestive heart failure with a history of COPD, it's much increased rather than COPD with a history. So you can discriminate if your patient has got a fluid due to pulmonary edema with or without congestive heart failure. Another paper coming showing that there is increase in the PNP with the different in progression of the NIHA classification of the heart failure. And saying that it is increased in a non-cardiac disease in this not dotted part. But if it is much more, as 2,500, it's most likely that this patient has got a cardiac disease rather than overvolemia. And PNP can be useful, as in the work of Chazelle in nephrology dialysis transplantation a year ago, that PNP useful tool to follow the dry weight and quest incidence. It is also a prognostic factor, but to make things not so easy, it is a prognostic with extracellular volume overload and cardiac disease. But if you have the volume removed, it is mainly related to the cardiac disease. And it is related to hospitalization because of the cardiac events. And if you treat the cardiac events, this will be decreased. The other point which can use is a whole body multi-frequency, and if you see it, decreasing hydration will keep the patient survival better if you measure this, but you will not use this hydration for every of your patients. So another point, what is the best way to remove the fluid? We may think that ultrafiltration is better than the standard care with the diuretics, but actually this is not in every respect. Definitely it works, it's removing the weight loss much better than the diuretic as Lasix, but actually there is no difference in the dyspnea score. And if you think about the creatinine, the ultrafiltration in red will have the creatinine to be better, but in the long standing after days, 30 days, it will be more or less like the diuretic therapy. But if you think about heart failure rehabilitation, all right, I have 2 minutes, and give me just 1/10 of the time taken by Professor Assam, otherwise I will feel discrimination from my chance. I'll finish. Ultrafiltration will decrease the decrease of rehabilitation of the hospital, and this is statistically significant. So I will left by 3 slides. Mr. Chairman, my take-home message is the volume expanded patient, difficult to distinguish the respective part of congestive heart failure and fluid overload in many patients. Underlying cardiac disease, very frequent in our patient. Echo and the hydration parameter with the multi-frequency are necessary to assess, evaluate both hydration status and cardiac function. Whatever the cardiac situation, fluid removal is the cornerstone of the treatment, whatever the reason is. it may improve the cardiac function. And ever, as Professor Essam mentioned, sodium restriction and use time and frequency in the dialysis strategy. I will not be happy if you remove 5 kilos in 4 hours. It's better to remove less and keep dialyzing the patient more frequent. The PMP changes may, and I press, may be helpful to diagnose fluid status and cardiac function changes and guide the fluid removal. Optimization of the cardiac function with medication may be necessary, but only after fluid removal. My last slide, Mr. Chairman, is my last statement. In absolute terms, adequate dialysis must be your aim. Being dry is much better than being wet, provided no contraindication and no complications. But still, it is individualized, however guided, not only by guideline, but rather with the clinical sense. And thank you very much.
Thank you, Professor Ahmad Adam, for your excellent presentation regarding the hydration and the fluid status observation all through the dialysis. And I really like the last statement that you said adequate dialysis and keeping the patient dry is the goal when we treat patients or to maintain him hyvolemic on dialysis. For the sake of the time, we just will have one question for Professor Ahmed. Any question?
Sir, is there any head-to-head control trials in the fluid removal in acute kidney?
Can you have a mic? I didn't hear you.
Is there any head-to-head control trials comparing the optimal method of removal of fluid in patients with congestive heart failure diuretics versus ultrafiltration?
Head-to-head between ultrafiltration